Good afternoon, everyone, and welcome to Grand Rounds Day on the 15th of April. Today is the 1 year and 1 day anniversary of when I had COVID. So it's a sort of COVID anniversary, and I think we're all starting to reflect on what the last year's been like and how things are different, how things have changed, and what things are going to be like as we go forwards. And part of what we've done over the last year is to look at the effects that COVID has had on the workforce. And so at Grand Rounds today, I'm pleased that we've got Lizzie Gordon, Gillian Scanlon and Achyut Valluri, who are going to come and speaking about the effects of COVID, the pandemic, on resilience in junior doctors. I shouldn't say junior doctors, it's doctors in training. But I think it is, you can extend that to all of us. It's not, we've all had our resilience challenged during the last 12 months in so many different ways, whether you've had COVID or you haven't, you've looked after people directly with COVID or you haven't. Everyone I know in NHS Tayside has changed the way they work in some way or other to help the effort. So we're going to hear them speak in just a minute, but before we do that, I've got a quick plug. The plug here is for the OSCEs. The university, the medical school has continued to teach all the way through the pandemic, and we need our our medical students to graduate because we need more foundation doctors next year, and things need to keep moving. So the medical school have done an amazing job to keep things moving, and now it's our turn to help out with the OSCE season. So OSCE season has started. The varying different grades of doctor and other healthcare professionals can help out with the exams. If you have a Unify account, then you can go to this link here in Unify to sign up for the OSCEs. There's a desperate need for the third year OSCEs and the fifth year OSCEs, which are the last week in April and I think the second week in May. So if you can help out, please do sign up to that. And I'll put the link in the chat as we go along. So I'm going to hand over now to Gillian, who's going to share her slides. I don't know who is starting first. Lizzie, perhaps, from the comfort of a wood. She'll tell you exactly where she is, I'm sure, when she starts her presentation. Okay, thanks very much. Gillian, do you want to just share your slides and we'll see how we go?
Yep, I'll just do that. So while we're waiting for Gillian to share the slides, I will say that I'm actually in my car because I've been sort of rushing. I had to rush somewhere in my cars, but the woods are actually quite accurate because they're nearby where I live. So the background is reasonably accurate as to where I am. So thank you everybody for joining us today. So what we wanted to do is present with you some initial findings from a very large study that's been going on over the past year or so, related to what we've given it as a sort of short name called the Scottish Doctors Wellbeing Study. The way that we're going to run this session is that I'm going to briefly introduce the project as a whole, and I'm going to introduce some of the findings, some of which probably won't come as a huge surprise to those of us that have been those of you that have been working clinically over the last year. And then I'm going to hand over to Gillian, who's going to talk about what we've done with some of the data and the interventions that have been developed, and then finally hand to Achyut, who will talk through the How's Your Day app, which is one of the interventions that's being that we worked closely with Achyut to develop, that's being run in Tayside at the moment. So first of all, just to introduce our team, we're actually a team of 14 researchers from all the medical schools across Scotland and NHS Education for Scotland. Sorry, if you go back, sorry, Gillian, just to the first slide. So we're medical education research as part of the Scottish Medical Education Research Consortium, and we got our heads together, and as part of the CSO Rapid COVID call last year, we we put together a proposal to explore, one of the priorities of that was to look at health professions, wellbeing and resilience as part of the COVID response. So what we aimed to do was to form a robust evidence base that informed the development and implementation of interventions that actually support the well-being and promote resilience of the doctors in Scotland. And we started with these two questions, which were the first question being how are doctors experiencing different transitions that are associated with the pandemic? And then the second question is, well, what interventions will best support doctors' well-being and resilience during these transitions, but also thinking beyond as well, and thinking long term. So not just for COVID, which is a term that I've come used to seeing in the Twitter sphere particularly, supports not just for COVID and things like that. So, okay, Gillian, next slide. So our project is what we've described as a rapid multi-stream project. The rapid being that we did a huge project in a very short time space, 6 months. We had four work streams. The first work stream being a scoping literature review to look at what interventions were available, what support interventions were available for health professions during previous pandemics and other types of crisis situations. The second work stream is an empirical work stream where we collected data, and it was a longitudinal study we've actually just finished the final part of our data collection related to that work stream. But alongside that, we were also looking at intervention design and implementation. So designing interventions that supported doctors during and beyond the pandemic and implementing those. And we have a final work stream, again, which is ongoing, which is around evaluating those interventions. Thanks, Gillian. So looking at the first work stream, as we said, we did a scoping review that looked at the types of evidence that was available in the field of wellbeing interventions for healthcare workers, and looked at whether there were any gaps in this area. So we did this sort of quite a very structured literature review. But what we found were that we found 13 papers that were included in this literature review. 6 were prospective studies, and the others were purely descriptive studies. So studies that were just describing, this is what we've done, and people seem to quite like it. None of the studies include any kind of theory around intervention development. And so we deemed that the quality of evidence was generally quite poor. So actually what we sort of thought was, we were kind of starting from scratch in terms of thinking about wellbeing interventions. And so, really, so it sort of gave us a basis anyway to think about in terms of working on work stream 2. So Gillian, thank you. So work stream 2 was empirical data, and that was led by myself and Gillian in the Dundee team. So we collected data from all the 14 boards in Scotland, and we went across the whole career profile. So I know Tom said about trainee doctors, but actually we had doctors all the way from foundation and at the time FIY trainees all the way up to retired returnees as well. So we had a huge spectrum, a wide range of specialties as well. And as I've said already, from all boards, so all geographical areas. So we did, in June, July last year, we interviewed 98 doctors. And of those 98, 71 went on to send us in LADs, which are longitudinal audio diaries, between July and October last year. So these diaries were sent in on a more or less on a weekly, fortnightly basis. And everything was about, well, what have their experiences been? How are they experiencing the different transitions that are associated not only at work with the pandemic, but also at home and in other aspects, educationally and things like that across their lives. And then we did a second interview in September, October last year, and finally we've done a final interview, just finished up a final set of 1 year on interviews with 66 of those 98. So an enormous data set, qualitative data set that focused around understanding what doctors and the stories of doctors' experiences through the COVID-19 pandemic. And that is, I mean, anybody that has qualitative experience will recognise that that is a really vast data set. So what I'm going to sort of show is a sort of quick overview of findings. Thanks, Gillian. So what we have come up with is that there are 8 key findings. So this was what we reported to the CSO. So people, so the challenges that people were experiencing quite often were a magnification of already existing challenges to people's well-being. And that well-being is challenged in multiple ways. So not just the sort of traditional, the way people think about well-being and the physical and the psychological, but also in terms of like social well-being, and that was in terms of communicating with others, colleagues, patients, and also cultural well-being. So related around to how valued they felt within the organisation and supported they felt by organisations, as well as how included they felt or excluded they felt within the organisations. Doctors experience multiple transitions across in multiple contexts, so not just with their role. So if people obviously, as I'm sort of telling people that already know this, that people were redeployed, people's roles changed, but also in the workplaces and educationally, things like education for a lot was paused during the time, and again, common to everybody globally, really, and personally and in the home as well. One of the strongest themes that came through is uncertainty. And that kind of sense of uncertainty that was both short and long term. So the very short term uncertainty that is quickly responded to, and that the adrenaline keeps you going and helps you respond to that level of uncertainty, to this kind of sense of chronic, ongoing. We don't really know what's happening. We don't know what's happening in the future. The future's uncertain, and that related to them individuals, but also to levels of organisational uncertainty and educationally as well for our trainee doctors. There was a sense, but from some doctors, of a lack of value felt by the organisations. For example, in some organisations, the R&R spaces that were put in place during the first wave of COVID were removed last July. And that feeling of, and for others that were not COVID facing, there's a sense that they were less valued somehow because there were no R&R spaces or less or fewer, opportunities for R&R space access than people that were COVID facing. Communication, organisational support through communication was also seen to be quite challenging. The huge influx of emails, the rapid changing of information as well, which what we're finding now is, as we're going through as things are settling a bit more now, there is a sense that the communication is more consistent and less of a flood and more of a stream of communication. So that was deemed something that is improving. And one of the things that we really picked up on, and actually is something that Gillian's going to talk about moving forward, was around the sort of acceptability as well as the ease of access to formal and informal support. And one of the key things that we identified within our data set was there is a certain stigma attached to accessing support and the consequences related to accessing support, and a sort of worry about the consequences related to accessing support was a theme that came through quite strongly. And finally, what we found is that everyone's having a unique experience, which means that a one-size-fits-all approach to supporting doctors during and beyond this time is not appropriate. So we have to take a multi-faceted approach to supporting doctors. Thank you, Gillian. So here's just a few. I mean, you can imagine, you know, we have thousands and thousands of pages of transcribed data, but here are some examples of some quotes that we've seen that some people may see as familiar to their own experiences. The first quote is around their experience of patients, you know, in the COVID ward, and how, you know, people, the lack at that point in the first wave, the lack of human contact with family and friends, and how you know that was something that came through quite strongly, was that experience of people not having relatives in, as what, you know, that to see, you know, their dying relatives, and then things like the experiences, you know, that this foundation doctor who found, you know, the visors and getting a bit foggy, not quite crystal clear, and then things are fogging up, and then because things are starting to fog up, they're becoming anxious because the mask's not properly sealed and the air's leaking out, and that made them more hot and anxious, and it fogged up their glasses more. So that's the kind of sort of the physical experiences and the physical impacts that people were experiencing. Thanks, Gillian. Another few data examples. So this is one that relates to accessing support, and you know, that people were, you know, what would help you, you know, that people, the message that it's sort of a cultural message about a stigma around accessing, and it's frowned upon about accessing support, and it's, you know, why be a wimp, you know, just, you know, sort of keep going, carry on. And the biggest message I give is it's not COVID that's it's creating mental health difficulties. So that's this GP is sort of is suggesting that it's the culture of not being able to, the stigma around accessing support that is one of the issues. And then this next quote relates to this uncertainty that comes in again around the future, their training post and their postgrad experience, and they'd had quite a good clear plan of what they wanted to do, and now they're less certain, and the experiences of redeployment and things has affected what they perhaps want to do, but also you know, it's affected their plans. And this final quote here is around a shielding doctor who was and the assumptions around going back to work, and trying to sort of negotiating the landscape of going back to work after shielding, and the difficulties that this particular person had, but also the conversations that, you know, that some shielding doctors reflected on around having to expose perhaps hidden illnesses and things like that, but also at the expectations of returning to work and getting back to normal straight away, and these types of things, that, you know, that sense of just getting on and just getting back to normal is something that we're sort of discussing and seeing in our data set and these third interviews, but not just with shielding doctors that are returning to routinized care, perhaps having not operated for a year. These types of things are beginning to raise concerns across our final data set. So that just gives you a flavour of this of the empirical side of the project. But I don't want to dwell on that bit. I want to allow Gillian and Achyut to talk about what we did about it with our study. So thanks, Gillian. I'll hand over to you.
Thanks, Lucy. So as discussed, I'll be talking through the intervention development process and briefly outlining the steps in which we undertook to prioritise the areas that were identified as important for doctors' wellbeing. So as Lacey kind of thoroughly described previously, we outlined 8 key areas that were important for doctors' wellbeing. And in doing so, we wanted to do further analysis around why they were important, so that we could take important steps forward to identify the areas which we wanted to prioritise, as well in helping develop our interventions. So after a thorough data analysis session with workstream 2, we then conducted 2 expert panel workshops in the summer of 2020. And these expert panel workshops, the kind of key elements we wanted to get around these was prioritising the areas to take forward, because we knew that there was multiple areas that we could target. But we started to think about things around organisational support, acceptability, but also ease of access to both formal and informal psychological support mechanisms for doctors. So in the first panel workshop, it was identified that 3 areas would be taken forward, and this was organisational support, psychological safety, and the physical safety, which is unsurprising considering the kind of PPE example that Lisa gave earlier. And we wanted to prioritise specific desired behaviours that we could move forward with. So we identified that the ability for individuals to access both informal psychological support and formal psychological support was a key area to take forward, particularly around the stigma that the doctors had described across career grades. Interestingly, about whether informal support, things like checking in with peers, checking with colleagues, speaking to a friend, as well, and the more formal support systems might be a counsellor seeking help from a psychologist as well. But we also identified that the provision of clear and transparent channels of communication were important, and having a provision of a clear action plan was important to take forward as part of the prioritisation exercises and developing the interventions. So we wanted to develop these ideas further, and we had quite a number of discussions within our wider multidisciplinary research team. And we then conducted another expert panel as well, and we really wanted to think about generating and progressing our intervention ideas. And that's where our focus started to shift around focusing on the stigma associated with accessing psychological support, and the specific interventions that we could then take forward to generate those ideas. So as a research team, and with the knowledge and expert panel workshops that also included stakeholders both at an organisational level but also at an individual level, we had a resultant idea that we wanted to promote and focus on the acceptability of accessing both formal and informal psychological support, but also the organisational support. And we really wanted to focus on these areas because what we had come to identify across the data over a long period of time now was that the well-being of these individuals was focused at an individual level, but also the key role that the organisation was playing in supporting and promoting the well-being of these individuals. So coming up with these ideas, we then started generating interventions that we could develop as part of the research and part of the empirical research that we'd taken forward. But we also thought that there would be existing interventions that might already be in place within the organisations that we could influence. We could change benefits, we could amend and adapt as well. So we developed 5 interventions that we're currently taking forward. And today we're just going to focus on 3 of these interventions, which will be the composite narrative animations, the wellbeing spaces, and the how was your day application. The other 2 interventions, which is the collaboration with the National Wellbeing Hub. So we've been having numerous conversations with the National Wellbeing Hub for over a number of months now about different ways in which we can influence the National Wellbeing Hub, ways in which we can input resources, some of our empirical research as well. And those conversations and discussions are still underway about ways in which we can inform that website and inform that working group as well. And the informal in-person psychological support is still in the development stages, so we hope to take that forward over the next few months. So we'll start with the wellbeing spaces. So as Lisa indicated previously, one of the important elements that we identified in the wellbeing of staff was these rest and relaxation spaces, and how important they were, not just for their well-being, but a sign that the organisation valued them as an individual, appreciated the work that they were doing, and gave them facilities where they could relax, they could integrate with their colleagues, they could access informal support. And I think that was one of the main benefits of these spaces, that it was away from the challenges of the ward environment. It was a place to interact with others as well, particularly with the social distancing and things that was going on, you know, not just in the workplace, but out with as well. It was a place to hydrate. It was a really just a place and a safe space, and that's what we were really trying to kind of tap into. Is it was this supportive space that was introduced by the organisation. Each R&R space offered, different things depending on the locality and the board, and even the hospital that you were working in as well. So what we were trying to depict in this image here is the different benefits that they offered, throughout the pandemic. But as Lisa indicated, some of these rest and relaxation spaces started to get removed as the study progressed, and that really affected the morale of staff. It really affected their engagement with their work as well, and it almost seemed like all the benefits and all the hard work they put in, was only a kind of short-term benefit, and it wasn't long-term, and the organisation no longer valued their well-being. So in order to kind of target this, we wanted to think about ways in which we could encourage boards to reconsider reintroducing these hospital R&R spaces. So we produced a persuasion document that outlined the benefits that these spaces offered in terms of the well-being of staff, but also the organisational commitment to staff well-being, and why this was important to staff. So we included, really kind of empirical research from our own data, but out with the data, and really we're talking about the importance of staff retention around about value and feeling appreciated as well. So, and then we included this really powerful infographic as well. So this document has now been sent to NHS boards, emphasising the importance of these spaces and highlighting where staff can readily access them as well. And currently we're doing some follow-up data collection on the specific R&R provisions that are available within each board in Scotland, and with an intention of forming a clearer picture and basis for future research and what we might be able to do in terms of informing about the types of things that staff might need in these spaces. But what we've kind of come to identify with some of the boards is that some of the R&R spaces have actually moved locations, so they've either moved out with the hospital as well. And what we're trying to get these organisations to do is to improve their signposting for staff, communicating that these spaces are available, that they can utilise them as well. But from our third interviews, we're actually identifying that some of these spaces Some of these spaces are actually very inaccessible now as well. They can't use, they don't have, you know, mobile phone signals or pagers, which is not beneficial for healthcare staff who are on call and need to, you know, just nip away for 10 minutes or so. So we're trying to think about ways about reintroducing localities that have removed them, enhancing these spaces, but also improving the signposting within these localities. So we'll continue to continue this work in the coming months. And I'll move on now and talk about the composite narrative animations that we've been developing over the last few months. So we're at the stages where we're developing 5 animations, and these are aimed to enhance the acceptability of doctors seeking formal and informal psychological support. And the animations, what they'll depict is the narrative stories that have been generated from the data that we've collected from all Scottish boards throughout this study. And what we want to do is ensure that the stories that we're telling are credible, are authentic to the important stories that we've heard over the last year now. And one of the animations, I'll be able to show you some extracts from that today, and that's Jane's story, which is a GP's experience during COVID. But what we hope to do in the long term and over the next few months or so is develop an animation from different cohorts. So from a foundation doctor's perspective, an early year specialty trainee, later year specialty trainee, and then a senior hospital grade doctor. And what we really want to get out of these animations is to inform those individuals that are viewing them more insight into the experiences of a doctor and the more holistic individual, you know, the professional challenges, the personal challenges that they go through. But within that, we also wanted to include, you know, help seeking as well, and individuals seeking out support for their well-being and whatever that might be, and persuading doctors to seek informal and formal psychological support. But additionally, to provide prompts and cues for a reflective practitioner as well, and reflecting on what they're seeing in the animation. And then finally, to have a model doctor or a role model for them to engage with and almost resonate with that experience. So to date, we have been engaging with a professional animation company, and they have been able to develop Jane, which is a 4-minute video of a GP's experience up until October 2020, because at that stage, that was all the data we had collected. And as Lacey said, over the last month or so, we've been conducting 3rd interview data. So we hope to take the other animations forward and develop them in more details and provide more up-to-date information, but we'll also be doing the same with Jane. So fingers crossed, I'm going to try and show just some extracts from the animation.
I chose to be a GP because I wanted to be a part of my patients' lives. But everything is digital and socially distanced now. It's changed our role utterly. I chose. Jeremy could see I wasn't fine. He said, "You can't care for your patients if you don't take care of yourself." As a GP, it's difficult to ask for help. But I did. Jeremy could see I wasn't fine. My informal support was my friend Sarita. We make a point of speaking at least twice a week now.
So hopefully you're able to see just some of the examples that we have in the 4-minute animation. But if you do want, you know, further information about Jane's experience, you can view that on our website. So in the 3rd interviews, what we started to do was show our participants this animation as well, and we wanted to. This is kind of forms part of the evaluation towards the animation. And we really wanted to get their, perspective and their first reactions to what they thought of this animation as well. And we've got an overwhelming positive response to date as well, talking about Jane's story being authentic, realistic, and uniquely fleshing out the depiction of what a GP's experience was throughout the pandemic. But I think even more important is that we've shown this animation to more than just GPs. Have shown it to trainees, senior grade hospital doctors, retired and returning doctors as well. And it's the story, it's being able to resonate in seeing either a colleague in this experience or seeing parts of themselves. And it's the ability where they're now able to put their hands up and identify that they might need help as well. And we do hope to kind of continue these other animations in the coming months and update Jane's perspective as well. But as I said, if you're interested in hearing more about the project and the development of the animations, you can find more information on the national, on the Scottish Doctors Wellbeing study as well. And I'll now hand over to Achyut, who's going to be talking about our collaboration with NHS Lothian and NHS Tayside in developing a new employee engagement app.
Thanks, Gillian. So hi everyone, my name is Achyut. I'm one of our acute medicine consultants here at Ninewells. So over the past 4 months, or actually 5 months now, all staff groups in our AMU have been receiving a daily prompt on their phones asking, how was your day? Now, the launch of the project, which was development within an existing online platform called Trickle, was celebrated in this recent Scotsman article with high praise from Lothian's Director of Medical Education and top doc, Simon Edgar. Julian, can I get the next slide, please? So I presume our own top doc, Tom Farden, was unavailable for comment that day, though it's possible, I suppose, since April 2020, his appearance fees might have gone quite up to the point that Scotsman wasn't able to afford him. But can I get the next slide, please, Gillian? So we'd actually been using the Trickle platform within AMU for over a year now, and there's some bonus material I can share right at the end if you're interested in hearing more. So when we launched How Was Your Day, that was sort of back in the start of December 2020. I suppose that was just as we were about to enter what's usually our busiest time of year. And with all the uncertainties about whether we were going into lockdown over Christmas, and with all the fears about the looming second wave, perhaps, despite, or I suppose perhaps because of, everything that was going on, a good number of people actually responded to these daily prompts. Could I get the next slide, please, Shilin? So individuals would then get weekly reports, I suppose partly for their own reflection and action as required, but we've been encouraging people to use things like Stephen Covey's sort of circles of concern, influence, control, to kind of help focus our energies on what's within our control, and whilst using platforms like Trickle to highlight issues that lie within our circle of concern. And now we've got several examples of how, by putting stuff out there, we can influence change that way. So perhaps more importantly, How Was Your Day is generating anonymous data for our senior team, which, sorry, can I get the next slide, please, Julian? Which then allow us to view live trends and fluctuations, I suppose target what might be going on here. Can I get the next slide, please? So, for example, we kind of noticed a worrying trend within the first few weeks of December, which I suppose was perhaps quite unsurprising, with admissions just really ramping up during that time. Can I get the next slide, please? But I suppose the data we were getting allowed us to really drill down and focus on what might be within our circle of control. I suppose this probably highlights how, little acts can make a big difference. The importance of looking out for one another, and I suppose remembering that that are the they that other people tend to complain about. So it's that whole thing about being the change you want to see and all. Can you get the next slide, please, Julian? So one of the things the Trickle platform allows us to do is post these sort of one-to-one fist bumps, as they call it, which is similar to the learning from excellence and the Greatix systems you've probably heard about. Other areas like ED have nicely demonstrated how these can improve staff morale. And I'm not sure if it's chicken or egg, but there does seem to be quite a close correlation between the giving of fist bumps and how people are feeling about their day. So Trickle does prompt if you've had a good day to give a fist bump, but we've also included that prompt in our own going home checklist and put posters up to remind people. But I suppose the problem is that with all the different starts and finish times in AMU, we've not yet managed to properly embed going through the going home checklist together as a team in our daily practice. And things like this just really need to be more than just a poster. So in terms of feeling valued and fulfilled, besides encouraging the use of fist bumps, a couple of our doctors in training are running a quality improvement project on improving feedback, including trialing of these sort of formal feedback cards with take-home points for our clerking doctors. I suppose a lot of this is focused on the medical staff, and as How Was Your Day's features are going to be expanding, that's going to allow us to drill down into certain staff groups and locations. I suppose with that data, better direct our efforts. So I've done a lot of work over the last few years on addressing the issue of lack of breaks amongst medical staff in particular. And we know that decision and I suppose compassion fatigue really starts to set in after 90 minutes. So we've structured our day into 2-hour bursts in between scheduled coffee tutorial breaks and board rounds. We're also using, explicitly using things like the Yerkes-Dodson stress response curve. Gillian, you might need to give it a click if it's not popping up. Yeah, there we go. At the end of the board rounds to get people to sort of reflect on where they are, I suppose what they should be doing. So either taking a break themselves or helping somebody else out. But again, I suppose a lot of this is focused on medical staff who tend to be present at the time. And as How Was Your Day data emerges, we're going to be able to go sort of more granular on where issues might be and direct efforts a bit more intelligently. So clearly this sort of Christmas, New Year period had been more difficult than most for a lot of people and for a variety of reasons. And data over that sort of festive period, if you want to call it, really reflected that. So 2019, I suppose, seems just such a long time ago now and such a stark contrast. Clearly we weren't going to be able to celebrate together in that same way. And the trickle that was started didn't really gather many suggestions, but with everything else going on, we probably missed an opportunity just to do something special, albeit in a safe, physically distanced manner. But as feedback from that week demonstrated, joy at work is important. But probably more importantly, we need to think about ways we can reconnect to joy in our work. What we do makes such a difference to so many lives, but it's easy to lose sight of that in the day-to-day bustle. So for a few years, we've been running weekly multidisciplinary values-based reflective practice sessions in our AMU. And oftentimes the busyness of the unit would get in the way, but whenever we just set aside those 30 minutes to pause and reflect, it really did seem worth it. And we kind of let the challenges of maintaining safe physical distancing during the pandemic, unfortunately, just kind of put a stop to these sessions when, really they could have been so useful. Going to get the next slide. But what we did trial was something different, and it was kind of inspired by the hashtag Spaces for Listening movement on Twitter. And we ran sort of 20-minute care space sessions, which are simple, sort of lightly structured process in which attendees have an equal opportunity just to share thoughts and feelings about what's on their mind, what's going on for them at the time. Going to get the next slide, please, Gillian. And then, clearly things like that aren't always going to be people's cup of tea, but it definitely seemed to be an appreciated offer. And I suppose it also does feel like we're becoming more comfortable as a department just expressing things that we might have previously just gone on and said. I suppose things that can really make a difference to How Was Your Day. So just as a final bonus slide, so if any of that talk of trickles whetted your appetite, or if you happen to notice in this year's CMO report mention of it, then if you go to that QR code, it links to a little story of our first year on Trickle. And Ali Mooney, just in case you're reading, I honestly did not say to the CMO that I am the acute medical lead. I didn't say that. So I'll hand you back over to Lizzie, and happy to answer any questions.
I don't know if Lucy's.
Oh, sorry, I just unmuted myself and talked to myself there. So thank you so much, Achyut and Gillian, for the second part of that session, and just some really big thank yous to a wide range of people, all the doctors involved in this project, the time that they took, the time that they spent, sending in diaries to do interviews, and comment on the interventions that we have designed. Obviously, all our collaborators, that have been, and people that have been advising us across the year, the CSO and the Scottish Medical Education Research Consortium for their funding. Thank you very much for listening, and we're happy to take questions in the last few minutes.
Thanks very much to Lizzie, Gillian, and Achyut for that. That's really fantastic. I was commenting somewhere or other just yesterday that the world of research has continued at a phenomenal pace during the last year, and I was talking mainly at the time about COVID research and the remap and cap and recovery, etc. But what we shouldn't forget is this kind of research has really been powering on as well, and you and your teams have really taken an opportunity here to do some fantastic bits of work, which and it seems like we're trying to benefit from something pretty bad, but that bad thing happened, and we can learn so much from how we respond to it and make things better. So thank you very much for your team and the work you put in, and I will single out Achyut for his work in this, because he works really tirelessly in the acute medical unit to looking after our doctors in training, and working really hard with this kind of work. So thanks to you as well, Achyut, for this. You really do drive things on. Does anybody in the audience have any questions? Either type them up in the side, or just stick your hand up or just start talking. Very happy to take any questions. Obviously, I said at the beginning that this was mainly doctors in training, but you proved me wrong immediately by talking about all doctors and all career grades and GPs, and so hospital and out of hospital. Have you thought about, or is it part of the scope to look at physician associates, advanced nurse practitioners, physios, AHPs, etc.? Is that part of the scope, or is that just a bit too big a project for right now?
Yes, so thanks, Tom. This current project was focused on doctors and this current piece of work, but there is another project ongoing which is going across and looking at brand new graduate doctors, nurses, and dentistry. And that's funded by Tenevis, and we're asking similar questions. We're asking about their experiences, and within that we have some new graduates who have worked as physician associates. But yeah, I absolutely agree with you. The fund and the opportunity was there to explore doctors, but there is a lot of messages that we can take away that cross-cut all professions, and particularly moving forward, things like GP practices, the changes in their practice, and how that will be affected moving forward. We certainly very much would like to look at that in a more interprofessional way. So yes, thank you. Appreciate that comment.
Has there been any work done from the CME or anyone else about medical students? It must, the impact we've had on fifth-year medical students who are going to launch themselves into this. Has any work been done on that? Does anyone know?
Well, as I said, the stuff, the work that's going with the 10 of us funded work is we're speaking to new graduates, but also there are some medical students there as well. And also as part of our BMSc, I'm aware of some work that's happening, exploring students, fourth year students as well, and their experiences. So we're trying to encompass as much of the career continuum as we can as part of this ongoing work. And the thing that I guess the opportunity that we've had in this last year is to explore things like doctors' wellbeing. It's an opportunity. It's something that we have been talking about for a very long time, and about the impact of working practices and experiences and on people's well-being, and so this opportunity. So yes, so it's certainly we're certainly looking across the career spectrum.
Okay, fantastic piece of work. Really pleased that you could come to Grand Rounds to talk about it. We had booked you in earlier in the year, and things contrived against us, but it was really nice to have you here with more data and a bigger picture. So if there's no questions from the virtual floor, then we'll pull things to a conclusion. Next week at Grand Rounds, we have Andrew Duncan, who works in the University of Edinburgh, and he is going to come and talk about his experience working in the lab that helped develop the ChAdOx vaccine. So that's the AstraZeneca Oxford COVID vaccine. That I think will be fascinating to hear his experiences from really inside the team. And he sent me his synopsis. It looks fascinating. So please do tune in next week for that. That's the 22nd of April. All the Grand Rounds go on our YouTube channel. The YouTube link is in the email I send around, or you can just Google Dundee Grand Rounds, and it's the first thing that pops up. Do like, subscribe, press the wee bell, and you'll get notified of all the Grand Rounds that get put up on the video channel. Thanks again to Lizzie, Atcha, and Gillian, and I will hopefully see you around and see you for Grand Rounds next week. Thanks very much.